refractory diseases. First, biological failure in rheumatoid arthritis. What next?
Oh, I can use this. Oh, okay, excellent. Yeah, it's even better. It shows, right? Yeah.
I request the chairpersons to keep the discussion on to 20 minutes, including the speech as well as discussion.
Good afternoon. Of course, we can understand the sparsity in the auditorium, the lunchtime. Hope everybody would be joining us shortly. It's a very interesting and stimulating lecture by Professor Carlos Emily. The first biologic failure in rheumatoid arthritis. What next? Professor, please.
Well, thank you. Thank you very much, Mr. Chairman. This is a key question. This morning we briefly touched upon the way that leads us to the first biologic treatment, and now we have to go for the highest hanging fruit. So how do we grab the fruit that's still on the tree after we're done with steroids, DMARDs, and then with the first biologic? So this is what we'll try to discuss. Number one, what do the recommendations tell us? And we'll see that our hands are very much free when it comes to first and when it comes to second line biologic. Second, when it comes to second line biologic or second line after a synthetic DMARD treatment, what should we use? Is it better to switch, meaning to cycle, especially with anti-TNFs, or is it better to swap, to change completely the mechanism of action? And thankfully now we have about a dozen molecules we can use in rheumatoid arthritis. And so the last question, which is probably the key, which second-line biologic shall we use? Well, if we go back to the EULA recommendations that we hinted at this morning, we see that we are left pretty much free, because it reminds you that you should add a biologic DMARD or a JAK inhibitor according to the current scenarios, to the current preferences that could be local, could be national, could be prescription limits, could be anything in there. So the truth is that in most cases, this is what we do when we need a first biologic. We spin the wheel and we say, what did I prescribe to the previous one? Oh, that was adalimumab. So this time perhaps I should go with etanercept or something else. So if we look at the marketing perspective, this is how the first line biologic changed from 2005 all the way to 2014. And we should also say that these are US data. So these data did include tofacitinib, but not baricitinib. And so if you look, the blue major part down here is etanercept. Infliximab has been getting thinner, that's the red part, while adalimumab, which is the lighter green part here, has been quite stable, if not decreasing in the second part. So should we switch or should we swap? Given that in most cases, the first choice goes to an anti-TNF, mostly for patients, because of patients who have been exposed to that, because of physicians' preference, as we mentioned. So why should we stop, and why do we stop anti-TNF treatments? Well, it could be that the drug never worked, primary lack of efficacy. That's approximately, I would say, about a quarter to a third. Someone would say half of the patients. Second, to me, is probably the major cause, is a secondary cause of failure, secondary failure. So the patient first responds. Let's remember that according to the treat to target recommendations, we should reassess the patient at 3 months. And if nothing has been achieved, we should then change treatment. That would be 4 to 30% according to the literature. It could be a non-satisfactory response. So we ask the patient, Are you happy with the situation right now? And most patients who have got significantly better, what was previously called the minimally clinically relevant important difference, would say yes, but many people, in some series up to 2/3, would say no. And finally, what we're probably most scared about, which is adverse events. People stopping a treatment because of adverse events. As you see, it's only about 10 to 17% of our choices. We are getting more and more demanding before switching a treatment. This is the reasons for the change in treatment, for the switching the first biologic in the first year, in the early 2000s, mid-2000s, late 2000s. And as we can see, quite interesting, adverse events were relatively stable over the decade, while the number of patients who were stopped for inefficacy were significantly higher. And this is probably related to the fact that we're expecting more from the treatment, and the patient is also expecting more from the way we treat them. And this is also mirrored by the fact that if you compare the level of disease activity at which patients have been switched with a biologic, we see that we've been going down, meaning that a lower activity has been pushing out more and more to change the biologic treatment. And this is, again, there's nothing wrong here. It's probably just that we're used to a better response. We're used to patient aiming at remission. So probably a 1, 2, 3 point decrease in DAS28 is somehow not sufficient. So in real life, what do we do once we're not happy? We're facing an insufficient response to the first TNF. Well, recommendations tell us that we should switch, we should swap, we should cycle, but reality is that sometimes we escalate the drug, particularly with infliximab, sometimes with adalimumab, but with adalimumab we have some limits because we can't go too much into the GI, the IBD dose, which is a weekly dose. We can cycle to a second TNF. We can play around with synthetic DMARDs. Increase methotrexate dose, add methotrexate in case it wasn't used, or change or add another synthetic DMARDs, particularly leflunomide and sulfasalazine. Finally, we can swap to a different biologic with a different mechanism, or we can swap to a JAK inhibitor. But if we go back again to the EULAR recommendations, we see that this is not even foreseen. Patients who have failed with a first biologic should definitely change the biologic treatment or to a JAK inhibitor. And in this case, there is no explanation whether you should swap the mechanism of action or should just change the TNF inhibitors. If words are important, we may say that in this case, a second TNF inhibitor is put last after the list of other mechanism of action monoclonal antibodies. What does the literature tell us? Well, the literature is quite scanty, and it's due mostly to retrospective data. This is a review article that my friend Ennio Favalli did a couple of years ago, in which most studies were from TNF versus rituximab in the second line. Most cases were retrospective, and in most cases, in the vast majority of cases, the swapping to a different mechanism of action, again, in most cases, was rituximab, was definitely preferable. And this is also mirrored by the second episode of the chart I showed you at the beginning. What happens in the market for the second line biologic over the same time, 2005 to 2014. We see that the etanercept part gets eroded, same for infliximab, same for adalimumab, and we do see the appearance of new players. Look, abatacept, for example, in orange, but also look certolizumab. Look at tocilizumab, which is the light gray. So again, it's a much more broader scenario, because reality is that in 4 years, the second line treatment will be discontinued by half of the patient within about 3 years. And with probably a sliver of advantage. This is a registry data for tocilizumab. And I'm quite sure, I'm quite confident That is probably because most people, after 3 years, sometimes demand to interrupt methotrexate, and we know the targeting IL-6 is advantageous when talking about monotherapy. So what is the second-line biologic? And here's, again, we know the recommendations. If patients should be treated with another DMARD, if a first DMARD may receive another TNF inhibitor or a biologic agent with another mechanism of action, no preference is stated. Current evidence does not suggest any one agent to be better than another TNF. Anti-TNF biosimilars have a different mechanism and need a different wording. At this stage, however, one should be reminded that we do have some limits in our choice, and these limits are mainly related to comorbidities. The infectious profile, particularly hepatitis B, hepatitis C, the past history of untreated or treated malignancy, the previous serious infections, and probably something we pay very little attention to, the presence of congestive heart failure, which, let's be reminded, should make the choice of an anti-TNF less advantageous compared to other mechanisms of action. In real life, these are data from Milan. We know that patients who switch overall tend to have, in this case, they're called cycling, meaning that they change molecule still targeting TNF, will have a lower drug retention compared to patients who swap. And this is regardless of whether the change is being due to inefficacy or to adverse events. So as to say that it doesn't matter why the first anti-TNF has failed, most likely changing type of target or therapeutic target would be advisable. If we take rituximab, we are reminded that in most cases, the seropositivity may predict the response to an anti-TNF rather than rituximab after the failure of the first one. And this is, again, something that's probably not surprising. But data are quite clear that if you have a double seropositive patient who has failed an anti-TNF, probably swapping to a rituximab could probably be more advantageous in terms of efficacy compared to changing anti-TNF. And then again, that should be. However, if we're talking seronegative patients following the first anti-TNF, probably the two choices are basically equal. So, and this puts everything we've said so far in a different light, meaning that probably being seronegative or seropositive should drive our decision since the very beginning and should probably make us digest the retrospective data a little better. What about abatacept? We have seen that it's been growing over time in the prescription pattern, especially in Europe. We know that abatacept has been perceived as a safe drug, as with less infections, has been perceived as a drug that is more effective if the patient is anti-citrullinate peptide antibodies. And we do see that there seem to be no major advantages when failing anti-TNF to switch to abatacept or another anti-TNF. But we now have two new kids on the block, and these are small molecules, the ones that target the JAKs inside the cells. We have two oral drugs, one is tofacitinib, taken twice a day, 5 milligrams. The other one is baricitinib, taken once a day, 4 milligrams. There is also the 2 milligram available. And we're very fortunate here, because while with other drugs we had to go through all these studies with time after the approval, we now have all possible scenarios here already available in terms of data. The naive patient, the biologic naive, the biologic failure, and we even have a head-to-head with adalimumab. So let's concentrate on baricitinib and the study on patients who had an inadequate response or intolerance to at least one prior anti-TNF. And the study was very simple, 3 arms for 24 weeks, either placebo or baricitinib 2 milligrams a day or versus baricitinib 4 milligrams a day. Patients had to be on a quite active disease, and we see it here, particularly if you look at the swollen and the tender joint counts, you see that the numbers were pretty high in all groups, so meaning we're facing a very, very active condition. The previous biologics did not differ, were not very surprising. You see, there were anti-TNFs, but there were also non-anti-TNFs, such as abatacept, tocilizumab, rituximab, even anakinra, and about 40 patients that also had known approved agents for rheumatoid. The cumulative results of this study, which was called RA Beacon, showed, quite not surprisingly, that baricitinib 4 milligrams, the red line, led to a rapid, look at here, 2 to 4 weeks, decrease in DAS28 compared to the 2 milligrams and to the placebo arm over 24 weeks. And let's remember that the 4 milligrams is now the approved dose for rheumatoid arthritis, although it can be escalated down to 2 milligrams. What about patients who had a previous exposure to TNF? Well, it's quite interesting to see that regardless of the type of anti-TNF, meaning etanercept, adalimumab, infliximab, at both week 12 and week 24, we saw the very same data, meaning that patients achieving an ACR20 were, regardless of the previous anti-TNF, led to approximately 60% response with the 4 milligram dose. When we look at non-anti-TNF, the picture changes slightly, particularly with the highest gap for patients who failed tocilizumab. And this is somehow quite surprising, because tocilizumab, we know, targets IL-6, and IL-6 is one of the main cytokines that are mediated through the JAKs targeted by baricitinib. So once again, this could be something to look into. Not surprisingly, patients who had failed more than one anti-TNF, to your right, versus those that had missed just one anti-TNF, had a lower response. Same thing for patients who had failed not 1, not 2, but 3 or more anti-TNFs or any biologic DMARD, and versus those that have failed less than 3 of those drugs. But I'm going to finish here with our own experience. These are unpublished data that we just gathered. They're really hot off the press. We finished analyzing the data 7 days ago. So we did a multi-center study in Italy, collecting 376 patients who were treated with baricitinib. This is real life, no prospective study. We asked the patients, who are the people, rheumatologists, there's about 12 rheumatologists involved. We asked, who are you treating with baricitinib? Well, the answer is quite interesting. We see the median age is about 60. The median duration of disease duration is 11 years. Double positivity is not surprising. 116 were biologic DMARD naive, and 206 took baricitinib alone, and 105 in association with methotrexate. I'll be real quick here. And at 6 months of therapy, 37 and 46% of patients had achieved remission. And if you want to use CDAI, which does not include CRP, the levels goes down to 17 and 28%. So we're saying that 1 in 3 patients will be in CDAI remission by 6 months with baricitinib. Of course, those that were naive to biologics had a better remission rates, and we also confirmed that methotrexate addition does not make a difference in terms of response. Patients who had stopped treatment due to ineffectiveness had done it in most cases in the first 3 months. So we can say that probably this is a drug that works well with the treat-to-target approach. If it's not responded within 3 months, chances are things that it will respond later. We observed 3 thrombotic events. 2 were deep vein thrombosis and 1 with pulmonary embolism, none of which was life-threatening within the first 3 months of therapy. So, I'm done. The algorithm is one thing, real life is another thing. If you hear someone from a podium or from anywhere else not having doubts when it comes to rheumatology, that means that he or she doesn't see patients. If you see patients, if you see lots of patients, you can clearly understand that the algorithms are like wearing a suit that's way, way too thin. And with this, I thank you very much for your attention and the great people I'm privileged to work with. Thank you very much.
Thank you, Professor. for your clear message. Now it's open to the audience that we may face this situation sometime or other. So if you have any queries, you can ask.
Carlo, do you have any experience of swapping between JAK inhibitors? Like
Swapping
one JAK
between-
inhibitor failed, what do you do? Like have you
no-
switched it to another JAK inhibitor? Or
You mean swapping from tofa to baricitinib or vice versa?
Do you have any experience of that?
Personally, I don't. I do have experience from switching from tocilizumab to baricitinib. Again, the axis has always been considered to be the same. So, but probably what we're blocking is more like GM-CSF in case of JAKs. So again, probably there's more than meets the eye in this case. I do know there's some people that are doing some investigator-initiated spontaneous trials of switching from one JAK inhibitors to the other. I have no idea what the data are.
Sir, the last question. We would like to keep up to the timings. The 2016 EULAR guidelines may be a bit older when we are halfway through 2019. And with such a robust evidence, in a cost-constrained situations as we have, why don't we recommend the JAK inhibitors at the first instance itself? Like you have a conventional DMARDs, inadequate responders, even after first biologic. Why to go about the second biologic or any other mode of therapy, then go to the JAK inhibitor? We can go
So
straight
you're
to JAK
asking me why we don't recommend JAK inhibitors to be right after?
right before.
Say again?
Right before.
Before the biologic,
Yep.
but after methotrexate.
Yes.
Well, as you have seen in about a third of the patients prescribed baricitinib, they were the first biologic being given. So I think that using the drug, one feels the experience, feels how the drug can comply with the patient in front of his eyes. So yes, I do. I can clearly envision patients that can benefit from baricitinib more than anti-TNF. And I can't tell you why, but again, with experience, I think you can get to that if you see how the drug works, because this is a fast drug. That's the other advantage. I mean, you get PROs going down by 4 weeks, and no one really bases his decision on fatigue. Who ever changed the treatment because of fatigue? I'm not gonna need an answer here, but certainly I have not.
Question from the app as such is in ILD, what are the pros and cons of using a rheumatoid arthritis ILD? What are the pros and cons of using a JAK inhibitor?
IL-6?
ILD, interstitial lung disease.
Oh,
Rheumatoid arthritis with ILD.
Oh, that's an excellent question, because JAKs have been used also for pulmonary issues. The data are not there, not these JAK inhibitors, but molecules targeting JAKs have been used in respiratory disease. There is really no data so far. We have been using it in this cohort. There were about 5 patients with ILD. Was not mind-staggering ILD, but they did just fine. My pleasure. Thank you. Thanks a lot.
So, for the next talk on applying ACR guidelines and resistant to treat psoriatic arthritis, I call the chairpersons, Dr. Binoy Paul and Dr. Chandrasekhara, to the dais, please. Dr. Jaswinder Singh will be the speaker.
Good afternoon. We will move to the second session, applying ACR guidelines in resistant to treat psoriatic arthritis. For this, we have a very eminent speaker from United States, Dr. Jaswinder Singh, who is the first author of the ACR guidelines that came in 2018. And he and his team has done a wonderful work to give a broad outline and some algorithms for the management of psoriatic arthritis. And I believe that he is talking a part of it, the resistant to treat psoriatic arthritis rather than the entire guideline. Dr. Jaswant Singh, please.
So good afternoon, and I'd like to thank the organizers for giving me an opportunity to share this with you. These are my disclosures. I think the most pertinent disclosure is what Dr. Paul just mentioned. I have an intellectual conflict, being the PI and the first author on the ACR-NPF guideline for PSA. So my job today in the next 20 minutes is to review with you 3 case presentations and to then walk you through particular aspects of the guideline. If I were to go over the guideline development and its details, it probably would take an hour or longer, and it'd be a very boring presentation, in fact, for many of you who are not methodologists but clinicians. So when we developed the ACR-NPF psoriatic arthritis guideline, our focus was to look at not only treatment-naive active PSA, but also PSA patients who failed a variety of therapies. And we did select a few comorbidities because these are common scenarios in clinical situations, as we've done in the previous ACR-RA guidelines. So before we go anywhere with the ACR guideline, the agreement is how to define active PSA, and the definition is right here. Active PSA is defined as disease that's causing symptoms and is involving at least more than one system, shown as with arthritis, dactylitis, enthesitis, spondylitis, skin, and extra-articular manifestations such as uveitis and inflammatory bowel disease. And these symptoms need to be unacceptable as per the patient and the treating physician. So you take into account all these domains, including the extra-articular manifestation of uveitis and inflammatory bowel disease. There are a variety of comorbidities, and we didn't have the bandwidth to address all the comorbidities listed here, but these are common comorbidities in people with PSA. We did include a few that I'll review with you in the context of the cases. So one thing to keep in mind is we'll be referring to some of these agents, and for this audience, this slide is maybe too redundant, but I wanted to put this up in case people are wondering when we're referring to an IL-1223 or CTLA or IL-79, what drugs are we referring to? We did include the drugs that were currently US FDA approved for use, as well as those that were possibly on the path and might be on the market by the time we actually get the guideline published. So you can see the list of those drugs right there. And methotrexate, sulfasalazine, cyclosporine, leflunomide, and primulast are labeled as oral small molecule for the purpose of this guideline. So this is the first case, a 45-year-old male who has psoriasis for 10 years, treated with topical agents and phototherapy. Increase in psoriasis over the last year, 5 to 6% body surface area, now scalp, elbows, knees, buttocks, and palms. Developed joint pain and swelling involving multiple joints in the last 6 months. He works as a concert cellist and is unable to hold bow. He has no inflammatory back pain. He's otherwise healthy, no history of IBD, CVD, uveitis, diabetes, liver function normal. He's mildly overweight, BMI is 29. He's got 8 tender and 6 swollen joints, tender at plantar fascia, no other enthesitis, no dactylitis, and knee aspirate shows somewhat inflammatory fluid. He's got elevated acute phase reactants. So the summary of this case, the way I see it, is he's got skin involvement, joints, entheses. This patient has no comorbidities and has not failed any prior systemic therapies. So the assessment here is that he's got active PSA. And the question is, what's the recommended therapy? So the guideline recommends TNFi conditionally over oral small molecule. But there are considerations. If the patient does not want to take injectable therapies or has concerns over starting biologic as the first agent, OSM can be used instead of TNFi. This is a conditional recommendation of TNFi being preferred over OSM. And if you want to refer back to the guideline, this is figure 3 in the guideline, and not sure how to get the pointer out there, but we're referring to this part. You're looking at treatment in IAPSA, and do pay attention to that blue box on your left that says that all these recommendations for this scenario of patients are all conditional, meaning that patient preferences come into play big time. But the recommendation, conditional recommendation is TNFi over OSM, IL-17I, or IL-1223. And right below that says may consider other therapies in some situations, and the figure legend will give you those situations, so does the text. And I reviewed a couple of those with you in the previous slide. What if the same patient, the exact same patient, now has failed methotrexate 20 milligrams weekly orally and is coming to you or was in your practice and now has failed methotrexate? Everything else is exactly the same. Now you have the same domains involved, you have the same comorbidities, none, but you have failed methotrexate. And the assessment, again, is that a patient has active PSA, and the recommendation according to the guideline is sort of summarized on the slide. And this is a synthesis of at least 5 to 6 recommendations, but I can review those with you. Here again, the recommendation is to conditionally switch to TNFi rather than switching or adding another OSM. And the guideline recommends that biologic monotherapy is conditionally recommended over a combination therapy of biologic and methotrexate, but you can consider adding methotrexate if you have severe psoriasis, which again is defined in the guideline document, or you're starting a monoclonal TNFi, in which case we know that using methotrexate will actually prolong the efficacy of the monoclonal TNFi and avoid the development of antidrug antibodies. Other biologics can also be considered in special circumstances because this is again a conditional recommendation. And if you have TNF contraindications, you have severe psoriasis, IL-17I or IL-1223I again are options for you. You may also consider maintaining methotrexate if the patient has a history of uveitis, because there's evidence from observational studies that continuation or introduction of methotrexate in people with uveitis is a benefit. And if the patient requires less frequent drug administration, obviously IL-1223 is an option. And if they have preference for oral therapy, then apremilast and other would be options as well. So again, this is going to figure 4 now, active PSA despite OSM. And again, you are switching to a TNFi over other OSM, IL-1223, 17I, abatacept, tofacitinib, and you can consider all these other therapies in the situation, which is what I reviewed with you in the last slide. Case number 2. Now you have a 35-year-old female with a history of psoriasis in age 17, treated with topical agents. Age 25, she's developed oligoarthritis, several joints, 3 tender, 4 tender, 3 swollen joint, enthesitis, dactylitis. She complained of inflammatory back pain. She was treated with etanercept 50 milligram weekly with good results. She reached MDI. That was a good 8-year trip for her. At age 33, now she developed severe diarrhea, mucus-laden stools, colonoscopy positive for inflammatory bowel disease. She's treated with tapering prednisone and enteric steroids. Etanercept was continued. And now she presents in your clinic with recurrent polyarthritis, 5 swollen, 6 tender joints, recurrent dactylitis, back pain. She smokes 1 pack per day for 15 years and has not been vaccinated against pneumonia or influenza. So here we have 5 domains involved: arthritis, skin, enthesitis, dactylitis, a new development of inflammatory bowel disease, and possibly a 6th domain of spondylitis. We have a patient who's a current smoker, that's a comorbidity, and they have failed their current etanercept. So the recommendation according to the 2018 ACR-NPF guideline would be to stop smoking. This is a strong recommendation in a smoker because smoking not only puts you at risk for a variety of tobacco-associated problems, but also reduces the efficacy of multiple drugs that she'd be considered for. Now, there are other recommendations as well, but let me just review with you the strong versus conditional recommendation. We only have 5 strong recommendations in the entire guideline document, and that's not because we don't want to make strong recommendations, but because strong recommendations require either a high quality evidence or moderate quality evidence, and in the lack of any risks. So high quality evidence comes from randomized trials that compare two therapies. Most of randomized trials have drug A versus placebo. When you're in the clinic, you're not deciding between drug A or placebo. If you were, we could make strong recommendations. But you're deciding between drug A and drug B. So that same evidence gets downgraded from high quality evidence to moderate quality evidence for indirectness, because you don't have the two drugs together in the trial. So strong recommendations basically would mean that most people in this situation would like to do that, and very few people would actually take an exception to that, as opposed to conditional recommendation, where majority of people defined as more than 50%, which is enough to win election in many countries, would do that, but a significant proportion of people may not want to do that. With the caveat now that for conditional recommendations, you really need to discuss this with the patient and take into account patient preferences and values, and it's not a done deal. Strong recommendations, you can make a recommendation. This is like somebody coming with a pneumonia to a hospital, antibiotics or no antibiotics. Antibiotics, strong recommendation. Jumping from an airplane, parachute, no parachute. Parachute, strong recommendation. So those are strong recommendations we have. MI, aspirin, no aspirin. Aspirin, strong recommendation. Because we have very high quality randomized trials where we actually have shown those things, except for parachute example. Nobody wants to do a randomized trial for that, and I don't think we'll have one. So that's the difference between conditional and strong recommendation, and that's according to the grade method that the ACR follows for development of guidelines and recommendations. So the recommendation here is to switch to a monoclonal TNFi, and switching to an alternate TNFi due to a secondary failure of initial TNFi, but you also have a recommendation, a strong recommendation that what you will do is use a TNFi or an IL-12/23I instead of an IL-17I, because we have trials of IL-17I that were stopped due to inefficacy of 17I in inflammatory bowel disease, whereas we have evidence of efficacy for TNFi and IL-12/23I. So that's why it's a strong recommendation. And another strong recommendation is to use monoclonal TNFi over a soluble receptor like etanercept, because again, etanercept has no efficacy in inflammatory bowel disease, and this patient just developed inflammatory bowel disease in context of her PSA. And to use the TNFi over IL-23I if you have spondylitis, again, because of evidence that TNFi works in spondylitis and some evidence that some trials of 12/23 were stopped in people with spondylitis due to quote-unquote inefficacy, but the companies are not forced to provide data when they stop trials. You'd also vaccinate this patient for pneumonia and influenza, and you don't need to delay the initiation of biologic for administration of killed vaccine, which is no news for this audience. Again, we are going to figure 5 here, and you're basically looking at a TNFi failure, active PSA, and this is where that recommendations come from. Case 3, 45-year-old female with history of psoriasis since age 17, psoriatic arthritis since age 40. She has history of arthritis, bilateral knee, bilateral wrist joint, again 3 tender, 4 swollen joints, enthesitis, dactylitis, treated with etanercept 50 milligrams with good results and reached minimum disease activity. She now presents with well-controlled disease. Her BMI is 28. She inquires about weight loss and whether to start exercise and what type. So the domains involved here are arthritis, skin, enthesitis, dactylitis. Her comorbidity is obesity or overweight, whatever you want to call it. BMI is more than 25. And her current therapy is etanercept. So what are the recommendations? You would recommend exercise conditionally over no exercise. Low impact exercise like Tai Chi, yoga, or swimming are preferred over high impact exercise like running as a conditional recommendation. And you would recommend weight loss in somebody with a BMI of 28 so that they can get down to normal BMI. So what I've shared with you is 3 cases illustrating how the 2018 ACR-NPF PSA guideline applies to common clinical situations. And although GRAPPA and EULAR have sort of mentioned TNFi among many options you can use, I believe ACR-NPF is the first guideline to say TNFi is conditionally recommended for treatment-naive patient. And this was Sort of a huge controversy in the beginning, but as we published it, everybody said, well, all other guidelines are already doing it, because I think times have changed. And we were at a time point that was a year or two after the EULAR and GRAPPA guidelines. So we were at an advantage point where we were able to make that recommendation. There are many other scenarios, and the guideline does help you with those. In fact, the 80 questions that we dealt come from 80 clinical scenarios or several more. And one thing that I want to say is, as a comment I made about classification criteria this morning, guidelines are meant to provide assistance to physician-patient dyad making the decision. Guidelines cannot tell you what to do. They can provide some guidance in the context, but the best decisions are going to be made by the patient-physician dyad, taking into account patient comorbidities and their values and preferences. So, as I said, 94% of our recommendations are conditional, only 6% are strong. That's not because what we want to do, that's because of the evidence that's available to date and the clear, transparent methodology that GRADE allows us to follow. And the evidence-based guideline covers the common clinical situations. Although recommendations are comprehensive, we could not cover all aspects of PSA management. We could not include fibromyalgia and several other conditions. We would have liked to do that. Otherwise, instead of a year and a half, it would have taken us 2.5 years, and we'd have to keep updating the literature. So there's a lot of research questions that the guideline brings up for us to think about, things such as head-to-head trials, more trials of mono versus combination therapy, vaccination trials, as well as studies of NSAIDs and glucocorticoids, etc. So there are several other topics that I think would be ripe and very opportune for the next set of ACR guideline, and they're going to hopefully move into living documents rather than 3-year periodic guidelines in the future. And they're going to be divided into segments that need to be updated every 2 years and segments that need to be updated only every 10 years. But hopefully that's the future of guidelines for the ACR. I'd like to thank Evan Siegel for sharing his slides with me. Many thanks to the ACR staff for their assistance. The guideline was funded fully by the ACR and the NPF, and none of this would be possible without the voting panel, literature review panel, working group panel, and probably about 15 to 25 individuals who worked on this project for a good 1.5 years, and then another 11 months during the revisions of the manuscript, and the review by another 50 reviewers at the ACR and the journal. So with that, I'd like to thank everybody and would love to take questions.
Thank you, Professor Isinder, for the excellent talk. According to the ACR guidelines, there is early use of anti-TNF agents. In a country like India, where majority of people cannot afford this drug for an indefinite period of time, we still give methotrexate, and we give other disease-modifying drugs like leflunomide or sulfasalazine combining with methotrexate. So we use all these strategies. What is your opinion?
No, I think that's a very good question. That again, the GRADE methodology allows us to take into account cost from the context and perspective of North America or the US, but not to limit therapies based on cost, right? So the recommendation is conditional to use TNFi over OSM, but you can actually, if you were to adapt the 2018 PSA ACR guideline to Indian perspective, you'd probably look at the same guideline and you'd reevaluate that based on cost and availability, and the toxicity might differ in the Indian population. So when you make a recommendation, you take into account not only benefits and risks, but also patient preferences, patient values, and cost. And they might differ based on the setting and the perspective. So is it possible that conditionally you might recommend OSM over TNFi for Indian perspective? Yes, it's entirely possible. But you'd have to go through that exercise in a formal fashion to know actually that you would do that, or you would add a condition of cost to that. And again, I didn't go over all the conditions where you would consider OSM over TNFi other than the two that I mentioned.
Yeah, the topic is open for discussion. Dr. Shanai.
Yeah, just a couple of points. Like methotrexate especially in South India, NASH is very high. So the LFT derangements, non-alcoholic steatohepatitis is quite high. So the tolerance of methotrexate is a bit difficult. And apremilast scores over methotrexate in certain aspects. And all of us across board, all colleagues feel that apremilast is working well, except that it has GI issues. So what is your take on apremilast?
So for the purpose of the guideline, we have lumped all the oral small molecules together, except when we went for the comorbidity of diabetes, because there's actually evidence from retrospective study with regards to liver toxicity of methotrexate in people with PSA and diabetes. And there, a specific recommendation is made with regards to the methotrexate-associated liver toxicity. I don't think at the time of the development of the guideline, we had convincing evidence even from an observation study with regards to liver toxicity of other medications. So in that context, in the context of diabetes, we have singled out, we have separated OSM into which OSM may not be preferred. But I don't think that there was an instance where we actually have preferred, because there was not evidence to our knowledge that's published. But there may be new evidence coming up in the future that might make us differentiate those drugs from each other. Again, one thing I'd like to emphasize is when we lump these two things together, we lump them so that instead of, if you lump 5 things together, you ask one question. So you have 80 questions. If you unlump the 5 OSMs, it's 80 times 5. It's a simple mathematics, 400. If you unlump the 5 TNFIs, it's 80 times 5 times 5, so it's 400 times 5. That's 2,000 questions, okay? And we've done 2,000 scenarios in 2011 for the 2012 ACR RA guideline, but that was RAND UCLA. So you can actually make people vote 2,000 times in 2,000 questions in a RAND UCLA and still let them come back, and they will do that. But the ability to do 2,000 questions with grade is not possible. But we still give our voting panel members a clear liberty to unlump the group when they think there's either the risk or the benefit differs within a group. Then we unlump every question into 5 or 7 or 10.
Dr. Carlos.
That was a marvelous presentation. Thank you very much. A very practical question. So we all agree that with active IBD, you don't target IL-17, and your hands are free if you don't have a history or anything pointing at IBD. What about in between? Patients have somehow a history of IBD or an elevated calprotectin. Does your decision change?
So I'll answer that with a caveat. I only do clinics 20% of my time. So I'm not a clinician, I'm a researcher clinician, so please take that into account as I weigh in. I do see patients with PSA, and I've been a rheumatologist for 19 and a half years. I don't think I've run into lots of patients like that, because I don't think I've seen the volume that a typical clinician sees. I think if you have a suspicion that somebody has an active bowel disease, even if it's undiagnosed or it's pre-IBD, I think I would stay away from IL-17. I think all other drugs are probably fine. And I think my answer would be the same in the absence of clinical experience for somebody with elevated LFTs. I think there probably it's even easier because you actually have a documentation of some liver problem. I would definitely stay away from drugs that, in my experience, have liver toxicity and would lean towards OSMs that don't have liver toxicity. That I have done a couple of times easily, but I have not run into the other situation. But we all know that if you look into the bowel of people with AS or PSA, that in 20 to 40% of patients you're going to find asymptomatic lesions. The question is when and who will progress is unknown, but if somebody has some early symptoms, I think I would perhaps stay away from 17I. Does that answer your question?
Thank you, sir. For want of time,
We are running short of time.
Any
Last
further
question.
questions?
Last question.
I just wanted to know, does it still holds true methotrexate not for plaque psoriasis, only for psoriatic arthritis? Sorry, I joined your presentations late. Because our dermatology friends, they tell, you people are very much carried away with the methotrexate. They normally don't recommend only for the skin part of the psoriasis methotrexate.
So if I'm getting your question correctly, you're asking if methotrexate should be recommended for psoriasis without PSA?
When it is PSA, psoriatic arthritis, not psoriasis.
Right, so the guideline is for PSA. I'm not sure it addresses, can you ask your question again? I'm not sure I got your question.
Thank you,
As
sir.
we all know, 30% has antedating skin infections and followed by arthritis. So our dermatology friends who see only plaque psoriasis, when arthritis has not evolved, they are not in favor of using methotrexate in all the cases.
Yeah, so I think you're asking about psoriasis without PSA. Yeah.
No methotrexate, no methotrexate.
And not using methotrexate. We did not review any of that literature because the National Psoriatic Foundation, NPF, is developing a guideline for psoriasis alone. The NPF, National Psoriasis Foundation, is developing a new guideline for treatment of psoriasis only, and so we didn't go there. We only went for PSA with one of the 5 domains, or uveitis, or IBD disease for this guideline.
Sorry, we have to
don't
stop
have-
because we are running short of time. Dr. Jaswendra Singh will be available at tea time. You can talk to him. Thank you very much.
Thank you, Chair, and thank you, Speaker. So we'll next move on to the next session. I will invite Dr. Pokri ma'am and Dr. Jacob Anthony to chair the session. And it's going to be our scientific chair, Prof. Rajeshwari ma'am, on refractory lupus nephritis. She has been the guiding force for the academic feast for the last 3 days for all of us. And she also has been honored IRA Oration Award last year. And she is a teacher for most of us. Over to you, ma'am. Thank you.
Now Dr. Rajeshwari needs no introduction. She is a well-known figure. She is the chief architect of this scientific program. So now she'll be talking on resistant lupus nephritis, how we manage. Over to Dr. Rajeshwari.
No. Yeah, as we are running short of time, I'll try to make my speech as crisp as possible. Thank you, organizing committee and chairpersons. Now, this is a very difficult topic, and we are not the ones who are treating isolated refractory lupus nephritis. Usually when it's isolated, they go to the nephrologist, but it's worthwhile knowing certain details because we treat them as a whole when they also have lupus nephritis. So in this talk, it will be the introduction, the definition, key terminologies, the role of fetal biopsy, re-biopsy, factors to consider while treating refractory LN, treatment, summary, and conclusion. So we all know that the kidney is the most frequent organ which is involved in a very severe way, and the clinical presentation is dominated by proteinuria greater than 0.5 gram per day with a urine PCR of 0.5 milligram per gram and urine protein 3+, along with an active urine sediment. So we should know about the silent nephritis also, which can occur in the absence of either of these markers, and a renal biopsy is absolutely mandatory. And moreover, it can be hidden by the protective effect of the AC inhibitors, which are given when they have massive proteinuria. Many a time, complete remission is not complete. 20 to 70% of them remain refractory after an induction therapy with cyclo or MMF, and when we maintain the therapy with MMF or AZA. Untreated LN, we all know, is a common cause of ESRD, and the aim of immunosuppression is to preserve the kidney function. Refractory LN can be a management challenge. Though they go in for clinical remission, 30 to 50% still have persistent histological activity, and there's a large disparity. Now, what is relapsing nephritis? When active disease occurs after total remission, refractory is, despite induction therapy, there is still active disease. Complete response and partial response both have to satisfy proteinuria less than 0.4 grams per day with a urine RBC of 3 per HiPA field. serum albumin greater than 3.5 and 3 in partial response, and the serum creat has to be 1.24 milligram per deciliter. However, the best predictor is an early decrease in proteinuria within the first 3 to 6 months after initiating therapy. And lately, in 2019, they have found intrarenal transcript expression profiles can express a molecular profile which can predict refractory LN. So EULAR, KDIGO, and ACR have given different definitions. For complete response, all should satisfy a urine PCR of less than 0.5, including in EULAR, the GFR should return back to baseline, and here in KDIGO, the serum creat to baseline. Partial response, it should be less than 50% of proteinuria to subnephrotic levels, and they should assume a normal renal function or near normal. And in KDIGO, it should be stabilization of serum creatinine with an improvement. And this should be achieved by 6 months, but not later than 12 months after initiation. Remember, there is no consensus for a definition of refractory LN. It's hard to differentiate or discriminate between refractoriness and irreversible damage. So this can be seen by the 9 various definitions given for refractory LN: failure to at least 1 or 2 immunosuppressive drugs, a poor response to at least 1 immunosuppressive, failure to immunosuppressives including cyclo, to any combination of immunosuppressives and steroid therapy for at least 6 months, failure to respond to MMF or cyclo, refractory or no response to standard treatment, and refractory to established therapy with steroid and immunosuppressant. So there is no consensus. However, a satisfactory definition has been described by EULAR, which is failure to improve within 3 months, no partial response after 6 to 12 months, and no complete response after 2 years of treatment. Now, what all should we consider? All this time we have been listening to refractory RA, refractory psoriasis. So the same thing holds good here also. So we should first see whether they adhere to the therapy, whether they tolerate the therapy, the adequacy of the drug exposure, the observation period, the adverse events, late presentations, and including vascular comorbid states like vascular complications and true lack of efficacy. Before changing therapy, after confirming the refractoriness and considering the comorbid states, we should consider a renal biopsy. And before that, we can try increasing the dose of MMF or switching over to entry-coated mycophenolic acid in case of intolerance to MMF, or increase the cyclophosphamide dose. When to do the renal biopsy? What are the indications? Almost the same in EULAR, ACR, and KDIGO. You should reproduce the proteinuria either in combination with glomerular hematuria or CAS, or in isolation, along with unexplained renal insufficiency. Just for recalling, class 1, there you see the podocyte. Can you bring that slide? That's a podocyte in the last picture. This is class 2, mesangial. Class 3, focal proliferative. Class 4, diffuse. Class 5, membranous. And 6, sclerosing. Now and this is the vascular complication or other cause of refractory LN. This is a thrombotic microangiopathy showing the thrombi inside the glomerulus. So we are worried about treating 3, 4, 5 and a combination of 4 and 5. Remember, podocytopathy is one of the causes of refractory LN, and variants of the ApoL1 gene are also one. After attending to the mimics, refractory mimics like adherence, blood sugar, BP, sepsis, and the vascular complications, we have to differentiate it from ESRD. Remember the vascular complications, all of us know that we have to continue HCQ, never stop it, aspirin, anticoagulation when needed, especially in APLA, and for thrombotic angiopathy, we know we have to go ahead with plasma exchange. ASRD, we know it's the replacement therapy. What are the treatment options? Now, switch over from MMF to cyclo or vice versa. We usually start with cyclo if it's class 4. CNIs, tacrolimus is very popular now. Combinations of MMF with tacro, it's known as multi-targeted therapy. Then we go to the biologics, rituximab, belimumab, which are being used. IVIG, immune adsorption, which has a wonderful response, and the others. However, randomized trials are missing, but we know that switching over from cyclo to MMF or vice versa, especially when switching over to MMF, there's a decrease in the steroid dose, the SLADE and proteinuria. Cyclosporin A in combination with MMF and steroids has been shown to be showing a good response. Voclosporin is a new find. However, the adverse events were serious. It's in phase 3 trial. Now, this combination therapy of tacro with MMF 4 milligram and 1 gram respectively versus cyclo 6 pulses has been shown to be superior with a complete response at 6 months for 4, 5, and 4 in combination with 5. Now, isolated MMF 2 to 3 gram versus tacro and with ASA maintenance has shown that tacrolimus is non-inferior to the combination therapy, but relapses are common, hence a combination is preferred. This is a multi-targeted therapy, both in refractory and relapsing. This shows that the steroid dose and the complement levels have shown a statistically significant improvement. Steroid reduction was possible. That shows a complete response and partial response. Okay, I think you can see. Now, as far as the mechanisms, all of us know about MMF, you can just read it. Tacrolimus, I think we should know, it stabilizes the podocyte actin cytoskeleton. That was what I was talking about, as podocytopathy is one of the causes of refractory LN. But the only problem with it is the nephrotoxicity, and the combination effects with MMF and tacro have a significant steroid sparing effect. So summary, as add-on therapy to MMF in refractory LN, the response rates have been between 57 to 90%. Rituximab, all of us know, the LUNA trial was a negative trial, it collapsed. It can be used as an add-on therapy with MMF or a fixed dose cyclo. Its dose is 375 milligram per square meter for 4 weeks with 2 fixed doses of cyclo, 0.5 gram per meter squared, 3 weeks apart, or a single dose of cyclo. Remember the reactivation of hepatitis B apart from the other side effects. The response is gradual. There shows a partial improvement by 6 months, which improves by 12 months. Single cycle shows relapses, hence it's worthwhile repeating cycles every 6 months. Monitoring B cells may be useful. In resistant cases, ofatumumab has been shown to show excellent response. However, there are only case reports. Belimumab in combo with rituximab, because it's supposed to reduce the bliss levels which increase after rituximab therapy. So combo with rituximab reduces also the NETs formation. However, long-term data are still warranted. Now coming to plasma exchange and immune adsorption, we know very little about immune adsorption, but abroad it has been used in quite a number of cases and is supposed to have met with a wonderful response. You can see at 12 months, the significant reduction in proteinuria, SLADE, ECLAM, steroids, as well as the anti-dsDNA levels after immune adsorption therapy. Autologous stem cell transplantation, good. Relapses are there, adverse reactions are there, highly related with mortality, especially when it was done when the damage accrual was more. However, when they used it in the earlier course with non-ablative regimens, it found a good response. Allogenic mesenchymal stem cell transplantation stimulates the proliferation of T regulatory cells, and it has been shown to reduce proteinuria and has obtained a good response. Other immunosuppressives are leflunomide, miserabin, which is an inosine monophosphate dehydrogenase inhibitor. I don't think I would like to have answers from the audience about leflunomide. IVIG, 400 milligram per kg per day for 5 days monthly. IV-AZA, I don't know how many have used. Methotrexate, IV with pulse cyclo, thalidomide, all are single case reports. Bortezomib, a protease inhibitor, has been found to reduce proteinuria. It can be given as a combo with rituximab or belimumab. Remember these important drugs, never ever forget them. HCQ, renin-angiotensin inhibitors, statins, aspirin, calcium, vitamin D, immunization, anticoagulant therapy when necessary, leuprolide, testosterone, all these have to be given. One important point, rough levels of blood HCQ less than 1000 milligram per ml have been shown to predict a flare of lupus nephritis. Not in all studies, but in many studies. So how do we go about it? EULA says switch from IV cyclo to MMF or vice versa, it's a revision, or go on to rituximab or tacrolimus or IVIG, plasma exchange for RPGN or immune adsorption. Same is given by ACR along with pulse therapies, 3 pulses of methylprednisolone. KDIGO says do a renal biopsy, and if you still find active lupus, then you switch over therapies, go to an alternative induction therapy before going to rituximab or IVIG. These are all only guidelines. As always, as I always say, treatment is always individualized. Now coming to 2 case vignettes, remember refractory, though we say refractory nephritis, though they look refractory, they may not actually be refractory. So this was a medical student who was 24 years old. She came to us. She was diagnosed by another rheumatologist. She had 20 grams of urine protein, grossly nephrotic. She was in renal failure. She had multiple infections, bacterial and fungal. She was resistant to steroids. She stopped MMF, went to native treatment, came back to us for the first time with renal failure. We tried pulsing her along with treatment for the infections. However, just 2 more slides, I'll stop. However, she did not respond. And then we boldly went ahead with IV pulse cyclophosphamide as per the NIH protocol. During the 3rd cyclo, we biopsied her. And this shows the class 4 in the first one, diffuse proliferation with a lot of interstitial inflammation and damage, interstitial damage produced by the native treatment. However, she responded so beautifully to the cyclophosphamide. Her PCR is less than 0.5 now with a 6 cyclopulse. So what appears refractory may not really be refractory. Apart from the clinical correlation, we also have to have a histopathological correlation. And she's resumed her studies now. That's good news for us. This was a young male. He was in the army, armed forces, and he came with a resistant nephrotic syndrome. His urine protein also was 20 grams, and he also had renal failure. He had resistant thrombocytopenia. Schistocytes were positive in the peripheral sphere. Coombs was negative. However, he never responded to steroids. Since we thought of TTP as a possibility, we gave him fresh frozen plasma. He couldn't afford plasmapheresis. And he developed a TRALI, a lung injury, and he also had developed superadded infection. As we investigated for atypical infections, we found his cold agglutinin to be positive, 1 in 64. And then we referred the textbooks and found that cold agglutinin with lupus has to be treated only with rituximab. And he responded beautifully. It just melted. He has no urine protein now. And that's the first picture, and this is the second one. So these are other problems which have to be looked into. Conclusion, there is no consensus on the definition. There's always a disparity between clinical and histopathology. Renal biopsy should be performed in a timely manner. Adherence to drug dosage therapy and the drug level should be checked. Switchover should be considered. never stop HCQ unless contraindicated. This is our modality of education. For a fair selection, everybody has to take the same exam. Please climb the tree, that's what the examiner says, and look at all the people standing of various cadres. But for lupus, one size does not fit all. Thank you for your patient listening.
Thank you, Rajeshwari Madam, for the wonderful presentation. Any comments, questions?
In Calcutta, which was organized by Professor Alukendu Ghosh, and there we got to know heard Dr. David D. Cruz. And Madam, I don't know, in UK they don't use rituximab, still they don't have here, they use belimumab.
Belimumab, I don't think it can be given as an isolation therapy for lupus nephritis itself.
But rituximab...
Only as an add-on therapy or as a combo, and I have no experience.
In the United Kingdom, they are using rituximab, they told. Rituximab they are not using.
Mild to moderate extrarenal, it has been used as an add-on therapy after rituximab to suppress the BLIS population. B lymphocyte stimulator.
Any other clarification?
Preferences, priorities about treatment, the urolupus or whatever it is. We follow only the NIH protocol even today. Unless otherwise it's contraindicated, we switch over to MMF after 6 months.
I'm just answering that question. I'm a consultant from UK. So what we use the belimumab is only.
Where are you? You're there. Okay.
Yeah. So I work in Cardiff. We use belimumab only for seropositive lupus. Like as you mentioned, for renal lupus, there's no evidence for belimumab. So rituximab has good evidence. So in UK, we use only belimumab for the people with seropositive lupus, like double standard DNA, low complements and stuff. But rituximab is mainly used for the renal lupus. Yeah, rituximab is used for renal lupus in UK.
If there is no more comments, we'll close the session.
Just one more addition. Rituximab as an isolated therapy, as I already mentioned, it's not really worthwhile. After giving a dose of cyclophosphamide or in combination with cyclo, it does work fairly well.
Thank you. Thank you very much. We'll close the section.
Thank you so much for your patient listening.
Thank you, ma'am. Thank you, chairpersons. So next topic would be refractory myositis. I would invite Dr. Chellapandian and Dr. Jyoti Sziracon to chair the session. And the speaker is Dr. Ramesh Joyce from Karnataka.
Good afternoon. At this session we take refractory myositis. Refractory myositis is the one we face every now and then in our practice. Sometimes we end up being unsuccessful even after using rituximab. So to throw more light on this, we have Dr. Ramesh Joyce here. Over to Dr. Ramesh Joyce.
Thank you, sir. I'd like to thank the organizers and Dr. Rajeshwari ma'am for asking me to be here. As Dr. Rajeshwari told you the earlier talk, there are some definitions of refractory lupus, but there are no definitions of refractory myositis. At least there is a guideline to be followed for lupus nephritis, but there are no guidelines for inflammatory myositis. So the job is much difficult. So what I'm going to do is to take you through what I would do in clinical practice when I see somebody with a myositis who is not following the usual recommended response. The first thing is revisit the diagnosis. Are you really treating inflammatory myositis? Because when you see a patient with isolated myopathy, the question is this inflammatory myopathy or is it non-inflammatory myopathy? exclude neurodegenerative disorders. We have all been caught in the wrong foot because so many of the times due to time or cost or whatever, we may not have done a muscle biopsy. There's not a person to interpret it. We may rely on only CPK. Early stages, they all look the same. And even neurodegenerative disorders may have a raised CPK. And patients may not present with associative features of connective tissue disease. We may not have looked into the drugs. So always look at the pattern of muscle involvement at the time of presentation, muscle atrophy or wasting and chronicity, some of the things, and also get your neurology colleague to examine the patient once to see if this falls within the spectrum of various degenerative neurological disease. So when a patient doesn't respond, it doesn't automatically mean that our only goal is to look at new therapies. You have to revisit your diagnosis. The next is, does your patient fall into a bracket? Classifying the patients is very important. Today morning we were hearing about classification versus diagnostic and how we said we should not probably be using the classification criteria to make a diagnosis and actual clinical practice. But I slightly differ in that having this criteria in your mind may actually help you to make sure you've covered all the various aspects of diagnostic procedures, because the previous criteria like the Bohan criteria had a lot of limitations, and then you had the EULAR ACR classification which gave weighted importance to what should be more important to us, because the previous criteria just said rash. Now what constitutes an important rash? The previous criteria never took myositis antibodies, whereas the present criteria just says anti-synthetase antibodies, but then we have so many other antibodies now after these criteria were written up. So it's not so easy to classify patients, but do take some time to sit down and say, how many of these tick boxes does your patient satisfy? And then see whether he still falls into the group of inflammatory myositis. So the other limitations of these classification criteria were it never took into criteria the MRI. MRI still forms one of the most important investigations, particularly when you look at patients who you think have isolated muscle disease who are not responding to conventional means. And I'll tell you a little bit about it later on. Obviously, this part all of us know. When you know that a patient is not responding very well, always rule out a paraneoplastic inflammatory myositis, look for an underlying malignancy. And then comes the resistant phenotypes. This is probably the main topic that I am going to be discussing. So when you see somebody with a conventional myositis who's not responding, the first question comes, is this active disease or is this damage? Do we have a lot of wastage in the muscles and that's why he's not improved, or are we looking at a patient who has really active disease? Because the CPK may not be high in all patients, so an MRI might help to look at inflammation versus fat replacement. Myositis is a disease which is very heterogeneous. So when you talk about resistant disease, the question comes, are you looking at resistant muscle, resistant skin, resistant lung, or resistant esophageal disease? And then there are rarer types of myositis which do not respond to a conventional treatment of steroids and other drugs, and that's inclusion body myositis and necrotizing myopathy. And unless you've carefully looked for them, these are two important phenotypes that do not respond easily. So always look for inclusion body myositis because they do not respond to steroids like inflammatory diseases. So early development of asymmetric quadriceps and finger flexion weakness and atrophy, dysphagia and weakness of the dorsiflexus of the foot are some of the clues, and all pathological features of an inclusion body myositis may not be present on a muscle biopsy. Sometimes we may be misled. Likewise, necrotizing autoimmune myopathy, weakness predominantly proximal, more prominent in the lower limbs, and in a recent Mayo Clinic review, it was shown that coexisting distal weakness involving foot dorsiflexors and finger extensors was seen in more than 40% of the patients. So this may be a clinical clue to look at that. That's because subacute presentation is seen in these patients, and neck weakness and dysphagia may be very common like what you see in other inflammatory myositis. And the levels of CPK usually are in thousands. There are two antibodies that are associated. One is anti-SRP, which we can test but the other one we can't. So that's why, and muscle biopsy may not be contributory because there is no or minimal inflammation, but a lot of necrosis and regeneration. So one is to look at the clinically. The other is, I think myositis antibodies have a big role today. This is one of the classical myositis profiles that we do in clinical practice that looks at the 16 antigens. And it's very difficult to remember each and every antigen of this. So that's why I've made this slide and I store in my mobile. And then when come with this unusual antibody, I look at my mobile and say, what is the association? Because it's not easy to remember. Why is it important? Because some of these antibodies have very high probability of prognosticating patients. That is very important because you know that you're looking at a very poor responsive disease. For example, you have patient with MDA5 who has an aggressive lung disease and the mortality is more than 50%. There is a very strong association of malignancy with SAE1 and TIF. Or NXP2 and SRP, we know necrotizing myositis. And amongst the antisynthetase, you know PL7 and PL12 are associated with a very high mortality. So there are a lot of things you can learn from these antibodies so that you can prognosticate them. And two antibodies which are new, which probably are going to revolutionize the way we look at it in future, although this is not currently available within our profile systems, is anti-cytosolic nucleotidase. This is going to be helpful because not all of us will be able to do muscle biopsies to look for inclusion body myositis, whereas this antibody has 98% specificity for inclusion body myositis. So this is going to be a very good marker in the future when it is commercially available. Likewise, TIF1 strongly associated with cancer. Majority of the people develop cancer within a year. So that also has a very good predictability for future malignancies. Then you have a patient with ILD. It's very difficult to know at the onset as to who's going to do less well in the future. So a low value of FVC, clinically amyopathic dermatomyositis, when you have predominant neutrophils in the bowel fluid, a pathological evidence of UIP, very severe skin disease, Hammond-Rich pattern on CT, absence of Jo1 ARS antibodies, because Jo1 confirms protection against ILD, but presence of other antisynthetase antibodies like PL7 and PL12 confers a very aggressive presentation of ILD. And I've already told you about MDA5 and very high ferritin. And if the patient is clinically rapidly progressing within 2 months or more than 50% affection on the CT scan. Why is it important to identify these resistant types? Because they need multiple drugs right from the onset. The moment you classify them that they are going to progress, do try multiple drugs at the same time. What is the evidence of treatment? Majority of the trials are open, uncontrolled, retrospective study designs, very small and selected samples because of the rarity of the disease and the difficulty in assessing them because we don't have proper response criteria, we don't have proper assessment criteria, short-term follow-up and ad hoc outcome measures. And multiple domains have to be looked at. And as I told you earlier, there is no definition for resistance. Steroids, we all of us use in our own ways. There's no RCTs till date. Optimal dose, duration, tapering, nothing is known, but high dose initially and favorable tapering. Methotrexate is a very commonly used drug for the myositis part of the disease. However, the evidence is based on many open label short case series which showed that methotrexate had a steroid sparing effect. A new trial is currently underway called the Prometheus trial, which looked at methotrexate plus steroid versus steroid alone. Preliminary results are not encouraging on 31 individuals, but the full trial is yet to be published. Azathioprine use once again is based on case reports in open label series. An RCT in polymyositis said azathioprine use continuously at 3 years reduced the dose of steroids and better functional outcomes. So it could be a good alternate to methotrexate in myositis and also in some patients for maintenance for those with interstitial lung disease. Mycophenolate is a very favorite drug. The moment we talk about ILD, everybody thinks of mycophenolate because it's an easy option. but the evidence in inflammatory myositis is very, very pathetic. Small case series, open label, a lot of that we have translated from scleroderma trials into inflammatory myositis. But however, there are encouraging reports from the existing data that ILD, mild ILDs particularly, skin and muscle are all benefited with MMF. Cyclophosphamide, we have traditionally used cyclophosphamide for ILD. Once again, this data is from scleroderma and Sjogren's. There are only 2 randomized retrospective trials and some case reports, monthly pulses of 6 months, which showed improvement in various parameters like dyspnea, oxygen improvement, FVC and HRCT score. There is about 40% improvement with the use of cyclophosphamide. Especially in those patients who are anti-MDF5, there are reports of combining cyclophosphamide with rituximab at the outset to improve outcomes. Very recently, an abstract has been published on the use of the Euro-lupus regimen for 6 months of using cyclophosphamide to reduce toxicity in patients with ILD, and the results are encouraging, but there are only 12 patients, and in them, all of them, the PFT and HRCT improved. So, even small doses of cyclophosphamide might work, but this obviously needs validation. Calcineurin inhibitors, particularly cyclosporin, has been studied extensively in Asian countries, particularly Japan and Korea. The most important lesson from cyclosporin is that early use of cyclosporin in ILD is important. It's not in the advanced stages of ILD. You can use it in early stages. It helps, it stabilizes disease progression and reduces mortality. Several retrospective data, it improves myositis, but anti-synthetase positivity is, it's better in patients with anti-synthetase positivity than negativity, and there is no difference for muscle involvement compared to methotrexate. Tacrolimus is once again a hot favorite amongst most rheumatologists now. That's the new kid on the block. What is the evidence? There are 8 studies to date involving 134 patients. All of them are retrospective, non-randomized. Only 2 had controls in them. And tacrolimus was combined with glucocorticoids, and it was shown that 93% of the patients showed improvement in muscle strength and 64% in physical function. CK reduced in all the 100% of the patients, helped in steroid reduction. 65% in this amongst the 134 had ILD. So tacrolimus combined with traditional therapy improved FVC and DLCO. And once again, anti-Jo positive patients responded better to tacrolimus compared to anti-Jo negative patients. IVIG is another favorite in inflammatory myositis, an expensive form of therapy that a lot of our patients cannot afford. But however, what is the evidence? 2 RCTs which reported improvement in muscle and skin, and 7 prospective uncontrolled studies involving 111 patients, and all of them various regimens have been used. Some have used monthly pulses of 2 grams over 2 days and given for 6 months to a year as the sole therapy along with steroids. But the general thing is that IVIG is good for muscle, it is good for resistant skin ulcers, it is good for dysphagia, and also it is good for patients with juvenile dermatomyositis where the response is far, far superior compared to adult onset, and those with HMG-CoA reductase antibody associated myopathy. Certainly for dysphagia, it's a very important drug. And some recent Japanese study has described its efficacy also in anti-MDF5. So IVIG in refractory inflammatory myositis, the new thing that is going to come up in future is subcutaneous self-administered IVIG, and if that comes, it will be very helpful. Rituximab, we all know that the RIM trial failed to meet a very complicated primary endpoint, but the eventual conclusion of the trial was that 83% of the randomized individuals met the DOI by week 44 and had a significant steroid sparing effect. The post hoc analysis was important because it showed that it helped a lot of different domains of inflammatory myositis, and better response was seen in JDM. So who would benefit from rituximab? Definitely JDM. Those with lower disease damage, and certainly anti-Jo1, anti-TIF and anti-MI2 patients benefit more from rituximab. And to date, 450 patients have received rituximab from published literature, and the average response rate is about 78%. The new latest paper in January 2019 comes from the Swedish registry on rituximab, which showed efficacy across the domains as I described, more so in antisynthetase positive patients. Then can we combine immunosuppressive drugs in inflammatory myositis? And one trial looked at combining cyclophosphamide, steroids and cyclosporin in 10 patients. The result was 50-50, 5 patients survived, 5 died. And azathioprine and cyclosporin have been combined. Rituximab and cyclophosphamide have been combined in a few cases. Cyclophosphamide and tacrolimus has been combined, particularly in ILD patients. There's this nice study which looked at TAC plus steroids plus cyclophosphamide versus steroids plus cyclophosphamide plus cyclosporin. So amongst the two CNIs, which is better? There was slight better outcome trending towards tacrolimus than cyclosporin. So tacrolimus may be preferred rather than cyclosporin. Just the last few slides. New drugs, tofacitinib in autoimmune myositis. Japanese study of a small number of patients, 3 patients survived, 2 died. Poor prognostic factors were the classical ones, and particularly tofacitinib has been tried in 18 patients with MDA5 positivity with some benefit. And these were the benefits that were seen. Infliximab, only 1 trial, 12 patients completed the study, 6 responded. Leflunomide, particularly helpful for resistant skin disease. So this is something that you could try in patients with resistant skin disease. Abatacept Artemis trial is one that has preliminary results which show some improvement. And treatment of resistant phenotypes like necrotizing autoimmune myopathy. The lesson learned from Mayo Clinic cohort was that, especially if you identify resistant phenotypes, give 3 or 4 drugs at the outset. Combining multiple drugs at the outset improves rather than using monotherapies. And anti-MDA5, corticosteroids, calcineurin inhibitors, and endoxin are the favored treatment. And skin rash, once again, tofacitinib, IVIG, leflunomide, and rituximab. The final last 2 slides I have. We have always been talking about inflammation in inflammatory myositis, but the pathogenesis has now shifted towards a lot of non-immune mechanisms that I have listed here, like ER stress, ATP metabolism, reactive oxygen species, microRNAs, and so on and so forth. So there are trials with these 2 drugs. One is sirolimus, which is being used in transplant literature, which is looking at completely targeting a different mechanism of action and not inflammation. So that is going to be the future. And also local therapy called follistatin gene therapy, directly injecting the muscle with gene therapy in myositis. So these are exciting things that are coming up. These trials are completed but not yet published on abatacept, eculizumab, and one of the non-inflammatory pathways, and methotrexate. And there are a lot of trials on belimumab, rapamycin, rituximab, tocilizumab is being looked at, and tofacitinib also. One thing that has been withdrawn is stem cell transplant. There were a high number of deaths and relapse rates, so stem cell trials have been withdrawn. So in summary, it's extremely difficult to decide which drug for which domain. But what I have listed here is some of them with whatever limited available evidence we have, that might help. I haven't covered calcinosis desperately because nothing works. A lot of things have been tried even in calcinosis, but that's one of the most difficult manifestations that would respond. And I would recommend this reading. It's a beautiful review for those of you who want to get an up-to-date knowledge about inflammatory myositis, which most of my talk was based on. Thank you very much.
Thank you. Thank you, Dr. Ramesh Joyce. That was a wonderful talk. And there's one question. How do you actually approach a patient who comes with a rapidly progressive myositis? You see in the ER, you send the prelims, it's about 2,000, 3,000 CPK. Next day you see it has jumped to 20,000, 30,000. How do you actually approach a patient? There's no time to add on, wait, and do a biopsy, nothing. How would you approach?
So if you're convinced that this is a rapidly progressing myositis, generally the phenotypes that are rapidly progressing are the necrotizing myopathies. And today, the only one thing that you can quickly do is to send a myositis profile. If your anti-SRP is positive, at least you know what you're looking at. But then we also have to be aware that a lot of patients may be antibody negative. Not all of them are going to be antibody positive. So when you have myositis that is rapidly progressing, obviously there's no time for treatment. The time-tested treatment is steroids. Obviously, big pulses of steroids is known to help. But there is no recommendation as to say what would be the next line of drug after steroids. But generally speaking, drugs like cyclophosphamide is not going to help a rapidly progressive myositis. If myositis is the only important domain, I think of all the existing therapies, rituximab would be a best choice.
Thank you. Want of time, if you don't mind, we could have the discussion during the tea break. Thank you. Sorry, really. So thank you, Chair. Thank you, Dr. Ramesh. So we'll go to the next one before tea break. It will be a panel discussion.
The panel discussion is on rheumatoid arthritis. The day-to-day questions we have, choosing the right DMARD or a biological RA in daily practices, also covers RA interstitial lung disease, post-transplant, renal failure, liver failure. And the moderator for this event is Dr. Moli Taba.
Can use this pointer, madam.
I call the panelist Dr. Hema, who's Assistant Professor of Rheumatology from Stanley Medical College, Dr. Kirti Talari, Consultant Rheumatologist, Yashoda Hospitals, Dr. Huma Karji, Consultant Rheumatologist, Manipal Hospitals, and Dr. Chengappa, Assistant Professor of Rheumatology, JUPMA.
Thank you, Kavita. Thank you, Rajeshwari ma'am, for having I think this is the only panel discussion in the entire 1.5 day conference. I welcome my brilliant panelists to whom all questions should be directed. Hema, Kirti, Uma and Chengappa. So bright and intelligent young people. So to move forward, we shall be discussing today on how to prescribe DMARDs, whether conventional synthetic or biological or targeted synthetic, in a special group of patients with Hep B infection, ILD, chronic kidney disease, pregnancy, and we'll touch a little bit on renal transplant also. So since because of lack of time, we'll move forward, prepare a little case scenario so that you'll become more interesting. So my first question is to Hema. We shall be discussing first of all a scenario of rheumatoid arthritis in the presence of hepatitis B infection. So Hema, yes, a 35-year-old lady recently diagnosed with rheumatoid. She has been started on methotrexate and sulfasalazine for 4 weeks. A patient was doing well, but on routine investigations, her physician found that she was positive for hepatitis surface antigen. So, in this context, what further workup is required before you proceed to start other DMARDs? And can you also tell us a little bit on which conventional synthetic DMARDs would be safe in a patient with chronic hepatitis and chronic liver disease?
Good afternoon, one and all. Like we are all aware that while the patients are on immunosuppressive therapy, the risk of reactivation of hepatitis virus is high. So the routine recommendations given by the American Association of Liver Disease and European Association of Liver Diseases, we have to do a basic workup before we start a immunosuppressive therapy for hepatitis. So these things will include hepatitis B antigen, that is HBsAg, anti-HBc. We have to do both IgG and IgM to know whether it's a recent infection or it's an occult infection, and you have also need to do an anti-HBs to know whether the patient is immunized. And of course, we routinely do your liver enzymes like ALT and AST, and others we would like to include is HBV DNA. HBC is positive to know the titers of HBV DNA, and the patient is found to have a liver disease, then you need to do an ultrasound therapy also.
Okay, can you just tell us regarding the conventional synthetic DMARDs which can be used in a patient having chronic hepatitis B without the presence of chronic liver disease per se?
Yeah. We are always at the risk of starting DMRs along with hepatitis B virus positivity. Even though the recommendation says that you can give a low dose of glucocorticoids, methotrexate, sulfasalazine and hepsequus, but it should be combined with an antiviral therapy, and this patient should be monitored regularly with your HBV DNA and also liver enzymes. But I would personally vote for sulfasalazine and hydroxychloroquine rather than methotrexate, because the risk is a little higher with methotrexate. But the scenario changes when it is going to be a chronic liver disease with cirrhosis. Here we don't use methotrexate and leflunomide. The safest thing will be sulfasalazine and hydroxychloroquine.
Yeah,
of course, sulfasalazine cannot be used in childhood's class C.
Now, what about the usage of biologics? Like, there will be a scenario whereby the patient doesn't improve, okay, having still active disease. Obviously, you have tried your conventional synthetic, methotrexate is being given, and low-dose steroids has been tried. Probably that's not worked. Then in this context, is it possible to offer this patient a biological agent?
Again, the recommendation says that you can use TNF, IL-6, rituximab in this patient, but with the antiviral therapy. Again, the risk is little low with TNF alpha, but the risk is high with rituximab, and all these patients should be given an antiviral therapy for a period of 6 months. But if you're offering a rituximab, ideally that should be continued for a period of 1 year, because the risk of reactivation is high with rituximab. Now, all these patients should be monitored by HBV DNA levels and also the liver enzymes once in 3 months.
Can you just stress a little bit on the importance of doing an anti-HBC? You may get patients who is, because routinely by and large, I think in the clinic, we all in the habit of ordering for hepatitis B surface antigen. Maybe an anti-HBS if there was a history of vaccination either. So what is the importance really of doing a total anti-HBC serology also in these patients before you begin immunosuppression of any sort?
I suppose that all of us will be doing only HBsAg and anti-HCV before starting an immunosuppressive therapy, but recommendation says that it is not sufficient. Ideally, you have to do an anti-HBC, that is core antigen, and also anti-HBs. If all the three are negative, then you can vaccinate the patient and you can start them on immunosuppressive therapy. But if hepatitis B, HBsAg positive and anti-HBC is also positive, we have to give them an antiviral therapy, and also you have to, you can start along with the immunosuppressive therapy. But if it's only HBC positive, it means it's an occult infection. So the recommendation says that you have to monitor this patient with the HBV DNA levels and also the liver enzyme. But suppose if you're putting these patients on a rituximab, you have to give an antiviral therapy along with your immunosuppressive therapy.
Yeah, this is quite important actually, because as you can see that in those patients who are anti-HBC positive, it means occult infection. And most of these patients may not have hepatitis B DNA titers also in high levels. So that's the importance of monitoring maybe every 3 monthly if it's feasible. Because it has been seen that in those patients who are anti-HBC positive, like absent surface antigen, and if they receive rituximab, then they can reactivate more commonly when compared to the patients who are negative for both surface antigen and anti-HBC. So what is to be concluded is that any patient who is surface antigen positive, irrespective of other status, whether HBC is positive, antiviral therapy has to be offered to all these patients, and currently it is entecavir and tenofovir, which is the drug of choice. Lamivudine is no longer preferred for treating such patients. And how long do we give antiviral therapy while patient is on?
Ideally for TNF and IL-6 other things, you have to give for 6 months to 12 months, but only they stress upon the rituximab, like you have to compulsory give for a year.
Yes, because rituximab has been found, with administration of rituximab, reactivation can occur even 6 months after stopping therapy also. So you want to overlap the antiviral therapy up to at least 6 months to 1 year. So moving on forward, my next scenario will be to Chengappa. Suppose this patient was HCV positive instead. Will this change the management? 3 questions I have for you. Is HCV testing recommended for rheumatoid arthritis in Indian patients? What challenges does HCV positivity pose to the rheumatologists? And can you tell also something about the safety of biologics in these patients who are HCV positive?
Thank you, ma'am. HCV itself has got a very varied incidence across India. If we see, one of the studies says it is almost as prevalent as 1 to 2%. That is as much as RA itself. But when we are looking at, since this is a South Zone Sziracon, when we look at the South Indian scenario, we have data from Tamil Nadu, which shows about 0.3% prevalence. This is quite a big study, about 18,000 patients, 18,000 people have been screened on a hospital basis. About 0.3% have HCV positivity. Now, does this mean that we should do HCV for everybody? Is it cost effective? That has not been known. But if we see the APLA recommendation, which has just come out, says that screening is a must for HCV. Why? One, because in a scenario of early arthritis, inflammatory arthritis, HCV arthritis becomes one of the differentials, which is good to catch and then treat. The second thing is, with all our DMARDs that we give for rheumatoid arthritis, there's a very high chance of reactivation of HCV virus. And then it is always better to start antivirals if a patient has both HCV and rheumatoid arthritis. Start off antiviral before and then go on to adding on DMARDs for rheumatoid arthritis. So considering this scenario, it is better to screen everybody for hepatitis C. So the second question what you had posed is, what are the challenges it poses?
Yeah, challenges.
One is in diagnosis itself, in a case of early inflammatory arthritis. HCV has got varied rheumatological manifestations, but arthritis is one of the more commoner things that we come across, and it closely mimics RA, at least in the early stage. So if somebody has very much of fatigue as compared to arthritis, then we can actually attribute it to an HCV arthritis rather than RA arthritis. HCV arthritis is generally non-deforming and is non-erosive, and there is no extra-articular manifestations of rheumatoid in HCV like rheumatoid nodules. And transaminitis is not very common in HCV arthritis, at least in early HCV arthritis. It is seen only in about 20% of them. Rheumatoid factor is a very bad marker to detect if it is rheumatoid or HCV arthritis, because in both almost 60 to 80% will be positive for rheumatoid factor. Anti-CCP could be of some help, but even there about 5 to 10% of HCV arthritis also may be positive for anti-CCP, but if it is positive in higher titers, it may favor rheumatoid.
Okay, thank you. Moving forward, what about biological agents in such patients? Suppose, HCV positive and rheumatoid with an active disease.
Biologics, as such, TNF is a favored biologic. This can be a take-home message here, because TNF has shown both decrease in viral load when we treat rheumatoid RA patients with HCV co-infection. The viral load tends to decrease, and the mean AST, ALT and liver function does not seem to deteriorate much. So overall, anti-TNFs are safe. Out of that, etanercept is the safest, is what has come out of the data. But if we compare between anti-TNF and rituximab, which are usually the two biologics that are used for RA, refractory RA, rituximab is a big no for HCV arthritis, HCV co-infection in rheumatoid at least, because as we can see in this graphs, post-biologic there is a high activation of viral HCV reactivation amongst patients with RA after giving rituximab. So rituximab may not be a preferred therapy. And coming to tocilizumab, there are a few case series, and there is a recent paper which shows tocilizumab, abatacept and tofacitinib. All the three seem to be relatively safe in rheumatoid arthritis with HCV co-infection. JAK inhibitors, though, has been proven safe. The number is very small, about 9, but we have to have a word of caution, because any viral infection is driven away by interferon pathway. So there is a viral infection in rheumatoid arthritis. We give a JAK inhibitor which essentially blocks the interferon IL-6 axis. So this could actually cause more resistance to viral clearance amongst these patients. And thus there is a basic paper which also shows this, that giving JAK inhibitors amongst RA patients with HCV co-infection has got interferon, in fact interferon production by dendritic cells is decreased.
What about the usage of, conventional synthetic DMARDs? I mean, cyclosporin is also a good choice, but apart from that...
Technically, all the conventional DMARDs are safe. If we get a newly diagnosed RA, we start off the patient with antivirals first, followed by starting off them with conventional DMARDs as we treat any other rheumatoid arthritis. Only thing is we'll have to have a close follow-up. Maybe even with sulfasalazine, it is better to follow them up once in 2 or 3 months. And if possible, it is desirable to do HCV RNA once in 6 months at least. Problem comes when there is a decompensated liver. So when there is a child class A, we can still go ahead with giving sulfasalazine and HCQ along with other biologics. Preferably any liver involvement, avoid leflunomide and methotrexate is the take-home message.
Yeah, that's correct. So basically, you need to look also as a liver functions, maybe an ultrasound. Nowadays, fibro scan is coming up. People look at the fibrosis also. If you detect any evidence of chronicity, it is better to avoid methotrexate, leflunomide at all. Probably, but sulfasalazine, low-dose prednisolone can be offered in such patients. Hydroxychloroquine can be given also, like in child A and child B. And from among the biological agents, most probably this TNF inhibitors appear to be safe. Lots of data is there, not exactly RCTs, but case series and reports which showed the no further activity with hepatitis C infection. So moving on, we'll go on to the management of chronic kidney disease in a patient with rheumatoid arthritis. As we know that rheumatoid is commonly we see proteinuria, commonly we see hematuria. So a case scenario here for Kirti is a lady who has rheumatoid for a few years now. She is seropositive, high ACPA titers. She also has got evidence of chronic kidney disease earlier, which has now progressed to stage 4 CKD. So in such a patient, which conventional synthetic DMARDs would be safe, and any dose modifications will be required or not? Can you just elaborate on that?
So here we are having a patient who has a background of chronic kidney disease and has rheumatoid arthritis that is established. So first thing is any patient with CKD, what we need to determine is the stage of chronic kidney disease. So that's done by looking at the GFR, wherein more than 90 is stage 0, 60 to 89 is stage 1, 45 to 60 is stage 2, 30 to 45 is stage 3, 15 to 30 is stage 4, and less than 15 is considered as stage 5 CKD. Now, the baseline drug that we all use, methotrexate, it's usually believed that it should not be given in any stage of chronic kidney disease, but it is contraindicated only in 3, 4, and 5 stages of chronic kidney disease. With dosage modification can be given in stage 1 and stage 2 as shown in the table. Sulfasalazine, again, with dosage modification, we can give it up to stage 4 chronic kidney disease. Leflunomide, we do not have adequate data from stage 2 onwards, stage 3 onwards, so it can be given in stage 1 alone. And hydroxychloroquine has been found to be safe in all stages of chronic kidney disease, but unlike other patients on hydroxychloroquine where we do a baseline eye examination and then repeat it after 5 years and then annually, in chronic kidney disease patients, right from the start, it's better to monitor them annually for retinopathy. In this patient was in stage 4 chronic kidney disease. So the drugs that can be given are hydroxychloroquine and sulfasalazine with a 50% dosage reduction.
Okay, thank you. Moving on forward, on follow-up, this patient at 6 months still seems to have active disease, synovitis is there, DAS28 is high. Maybe it's time to consider, a biological DMARD or newer agents like smaller molecules. How would you proceed in such a scenario?
So this patient is not responding to conventional synthetic DMARDs. So we'll have to consider either biologic DMARDs or traditional synthetic DMARDs. So among biologics, all the biologics have a high molecular weight. They are not filtered at the glomerulus level. The only biologic that can get filtered at the glomerulus level is anakinra, which is not available in India. So almost all biologics can be considered safe in renal dysfunction. And we have pharmacokinetic data for all of them. While traditional synthetic DMARDs are primarily excreted through the kidney. So in patients who have stage 3 and below, baricitinib cannot be given Above that, that's like stage 2 and 1. With no dosage modification, baricitinib can be given. While tofacitinib can be given up to stage 3 with modification of dose, wherein we decrease the dose to 5 mg per day in stage 3 chronic kidney disease. And below that, that stage 4 and stage 5, it is absolutely contraindicated.
Okay, so again here the message, our anchor drug, that is methotrexate, probably is contraindicated here. So we'll not be able to use. And important to remember also among the target synthetic DMARDs that as the stage of CKD progresses, maybe stage 3 onwards, we would have to have the dose in stage 3, but 4 and 5 is better contraindicated. So, but a safe message here is that apparently this TNF inhibitors are safe in renal dysfunction. Okay, moving on forward, we'll go to the scenario of interstitial lung disease. Today morning itself, we had a very good lecture on the ILD patterns in connective tissue disease. And we do see patients also who have stable ILD. So I have a patient here who, usual scenario actually which we see, 45-year-old lady, rheumatoid for 10 years, appears to be doing well with DMARDs like methotrexate and sulfasalazine. DAS is also 3.2. And she's non-diabetic, but of late for the past 6 months or so, she's been having shortness of breath, dry cough and progressive. Naturally, you would suspect interstitial lung disease, and an HRCT had shown a UIP pattern. Now this question is for Uma. Can you just elaborate on the management of arthritis in this patient? I mean the arthritis, and also touch a little bit on the management of ILD also.
So the first question is to continue or not continue methotrexate, which is a million-dollar question. I'm sure if you ask this question to everybody in the hall, they're going to have a different opinions. In this case, especially, I would do a full set of lung function test to look for a FEV1, FEC, and a DLCO. If FEV1 is more than 1 liter, then you can continue the methotrexate, but however, it has to be explained to the patient if there is any worsening of symptoms or anything to come back or seek a medical advice. If in a different case scenario, if the patient has been completely well on methotrexate and the incidental finding of ILD while doing the CT for some other reason, in which case if it's a very early ILD, then you can continue methotrexate. However, you have to follow up very closely with a 3-monthly lung function test for this group of patients. So actually the worry here is if the patient develops hypersensitive pneumonitis induced by methotrexate, there should be enough lung coping strategy should be there. That's the reason there is a worry about methotrexate. But however, there is no absolute contraindication to stop methotrexate if the patient is stable on methotrexate with a very early ILD. The next question is methotrexate-induced hypersensitive pneumonitis, when to suspect? It usually happens within a weeks to months. After 10 years of being on methotrexate, it's very, very unlikely to be hypersensitivity pneumonitis. And also radiologically, you can differentiate whether it's a rheumatoid-related ILD or a hypersensitivity pneumonitis. Coming to the third question, there are case reports of leflunomide lung toxicity. I haven't personally come across those scenarios, but I have read about these case reports. So maybe a little bit cautious about the leflunomide.
Okay, thank you. So most important message is that methotrexate, lots of data is there. Per se is not associated with pulmonary fibrosis. Especially this patient has been going on for 10 years, doing quite well. Probably this ILD has been there all along. It's not at all related to the methotrexate. Another point is that, which Uma has said, that hypersensitive pneumonitis generally occurs early on in the, soon after initiation of methotrexate. So, but the different, diagnosing of it is of course difficult. Lung biopsy we do not do. So short of stopping the drug and seeing for response, no other way can we confirm. And like she correctly mentioned, leflunomide toxicity has been reported in the literature, although both these conditions are very rare. So moving on forward, in case her ILD is bad, arthritis is stable, and which you decide probably a biological agent is required. Can you just tell what biological DMARD will be useful for her?
So, the patient is worsening, basically, so we are thinking about now giving biological DMARDs for this patient. There is, initially when the anti-TNFs came, were licensed, at that time, as per the guidelines, there was absolute contraindication to use the anti-TNF treatment in this group of patients. However, lately, there are reassuring results from the registries all over the world that there is no absolute contraindication for the anti-TNFs. You may consider individualized to each patient if they do not have a severe interstitial lung disease. So basically, if they get an infection, if there is enough lung is there to cope with the stress, then you can give the anti-TNF treatment while monitoring closely. There is no particular anti-TNF which can worsen or induce the ILD, which has been very reassuring. At the same time, there are rituximab, tocilizumab, abatacept, and lately the JAK inhibitors have shown good reports, and they have not shown any worsening of features of ILD. The third question is if the patient is reluctant for the IV biologics, then we have an option of subcutaneous abatacept. However, it's not available in India. The other option is using JAK inhibitors, either tofacitinib or baricitinib, for these patients, mainly to control the joint disease.
Right. So regarding the issue of TNF inhibitors inducing or worsening interstitial lung disease, data is not there from RCTs, as we all know that such patients are excluded from randomized clinical trials. So, but there are case reports, in fact, systematic reviews, meta-analysis, systematic review of 122 cases earlier in the 2014 or 15, this paper was published, whereby it was found that patients who receive TNF inhibitors can have a worsening or exacerbation of underlying lung disease. But those patients who had this worsening, they had a pre-existing bad disease altogether. They were older, they were smokers and all. So, but as such in clinical practice, TNF inhibitors very rarely produce incident ILD. Maybe an exacerbation, but that is also very, very rare. In fact, this topic can still be discussed, but it's always better to maybe be cautious and monitor carefully if suppose you have to give a TNF inhibitor to such a patient. When they compare the incident ILD between TNF inhibitors, between non-TNF biologics, the development of ILD was the same actually. This is basically from US data, from this Medicare from California. So moving on forward, we'll touch a little bit on the issue of pregnancy. Kirti, I have a question for you. So this lady is 22 months pregnant, rheumatoid, 1 year, not treated properly as usual as happens in our country. And she goes to the gynecologist because she desires an MTP because, people are saying that the medications you are taking are toxic to the baby. She wants an MTP. So this gynecologist refuses to do. She knows Kirti, who is a friend of hers, and refers this patient to her. So how will you approach this patient? I mean, what will be the management for rheumatoid in a patient who is pregnant at 22 weeks?
First of all, I would like to thank my friend who has decided that she should not be the one who should be managing RA in pregnancy and has been smart enough to refer it to a rheumatologist. So when we look at the DMARDs that can be offered in pregnancy, first, DMARDs that are absolutely contraindicated in pregnancy, methotrexate, leflunomide, tocilizumab, abatacept because we do not have adequate data, and JAK inhibitors again because we do not have adequate data. Drugs that can be offered in pregnancy, corticosteroids can be given during pregnancy. We know that fluorinated corticosteroids like dexamethasone, betamethasone cross the placenta and reach up to 50% of their levels in the fetal circulation, while non-fluorinated glucocorticoids are degraded by 11-beta hydroxylase in the placenta, and hence only about 10% of the total dose that is given reaches the fetal circulation. Previously, it was believed that glucocorticoids increase the risk of cleft lip and cleft palate in the child. that was one more worry that was there. But in a systematic literature review that was done between 2008 to 2015, which included about 3,500 pregnancies, they have found that glucocorticoids given at the lowest effective dose do not increase the risk of congenital malformations, do not increase the risk of infections, do not increase risk of premature deliveries, premature rupture of membranes, and hence can be given at the lowest effective dose. And if we are giving corticosteroids throughout pregnancy, it is better to give stress doses in the peripartum period. If you look at NSAIDs for pain management, NSAIDs before conception are usually not to be given because they have a 35% risk of luteinized unruptured follicular syndrome resulting in infertility. So among all the NSAIDs, if we, in the first half of pregnancy, NSAIDs, non-selective COX inhibitors, have adequate evidence to say that they do not cause any problem. But beyond 30 weeks, NSAIDs can cause premature closure of ductus arteriosus. They can cause pulmonary arterial hypertension and also fetal renal toxicity with oligohydramnios. So NSAIDs can be given in the first half of pregnancy. If you look at sulfasalazine, the meta-analysis for sulfasalazine for its safety in pregnancy comes up only in inflammatory bowel disease patients. 525 pregnancies where they found that it is safe during pregnancy, but at a dose of 2 grams per day only. At 3 grams per day, there have been cases of congenital neutropenia, and hence it is at 3 grams per day it should not be given. A folate supplement of 5 milligram per day should be continued throughout pregnancy. Antimalarials, hydroxychloroquine at 200 to 400 milligram per day has been found to be safe. Chloroquine, however, reaches 2.5 times higher levels in the infant, and hence should not be given because of the risk of ocular and ototoxicity.
What about biologicals?
So coming to biological DMARDs, the most well studied are TNF alpha inhibitors. All of them can be given in the first half of pregnancy up to 22 weeks. Beyond 22 weeks, because this is infliximab, adalimumab being IgG1 monoclonal antibodies, they can get transmitted via the FcRn receptor into the baby and can reach concentrations as high as 150% as compared to the maternal blood level. While etanercept and certolizumab do not cross, and the levels are as low as 0.3% with etanercept and 3% with certolizumab, and hence throughout the pregnancy certolizumab and etanercept would be safe. In the first half of pregnancy, infliximab and adalimumab can also be given.
Okay, thank you. So basically, prior to conception, obviously, if the disease is well controlled, then less likely we'll have to resort to biologics and stuff. So we might only require, the conventional synthetic DMARDs only. We have 2 more scenarios, but since we don't have more time, I'm going to close. I will just summarize. So basically, lots to discuss actually, but we don't have the time. So screening for Hep B and Hep C is recommended for all patients. It is essential rather, especially because anti-HCV has become a treatable disease nowadays. Anti-HBC helps to identify occult hepatitis B infection. Most stage 2 and stage 3 CKD can be managed with methotrexate. TNF inhibitors are supposedly safe in chronic kidney disease. In advanced CKD, you would like to avoid methotrexate and leflunomide. Methotrexate per se does not cause pulmonary fibrosis, but we have to be aware of hypersensitivity pneumonitis, and the incidence of ILD occurs similarly in both TNF inhibitors versus non-TNF inhibitors when you look at the incidence of ILD. And in pregnancy per se, we would like to avoid methotrexate, leflunomide, and rituximab therapy. And also in the first half of pregnancy, TNF inhibitors are probably safe, but in the second half, it's better not to give. Thank you all for your patient listening. We would like to take some questions if there are any.
I just have one comment, it's not a question. I would never like to add fuel to fire. TNF inhibitors are expensive, and I would not take the risk, that is my personal opinion,
yes,
of giving TNF in patients with ILD when there are better drugs available. And I think tocilizumab is a safer option now.
Anti-HBC, sir, at the baseline itself, that the idea is to rule occult hepatitis B infection.
because the DNA integrates with the host DNA. There is something known as a cccDNA, which can be detected only by doing a liver biopsy. And these are the patients who require more monitoring because it reactivates. Yes, sir. We never knew this, but we must do actually. We don't do, sir, but we will have to include it. At least in our hospital, we are doing Hep B surface antigen, anti-HBC, IgM and IgG, and also if there was a history of vaccination, titers for protective HBS. Yes, sir. Total, sir, IgM basically recent infection, IgG for past infection. I'm not a gastroenterologist, but total is recommended, sir. IgM, it indicates a recent infection with hepatitis, with HBV, sir. Yes, sir.
So regarding leflunomide and...
Hema, can you help? Maybe you can explain to sir properly.
See, all hepatologists recommend anti-HBC. You have to do the core antigen according to their protocols.
Even in carrier states of HBsAg,
Yes, Dr. Subramaniam, yes.
Even in carrier states of HBsAg, I mean, it's difficult to convince the hepatologist to start antiviral treatment.
We have to treat, sir. It's
Even
very important. Actually, we didn't have time, but lots of data showing, reactivation with DMARD therapy.
And what about?
Madam, regarding leflunomide and CKD, as data is not adequate, should we use leflunomide?
Avoid.
Till what?
Maybe till
stage 1, it is recommended to be used, sir. Stage 2, 3, 4 and 5, since the data are inadequate, it is recommended that we do not give leflunomide in those stages.
What was your question? Can you say it? Yes.
What about HBsAg vaccine?
Vaccine, those who are negative for all three, you have to vaccinate.
See, ideally,
Negative for HBsAg, negative for anti-HBC, and you have to vaccinate. And the dose is double. It's not the single dose which you give for normal people.
You have to do a double dose of vaccination.
Yes.
Ideally, the recommendation is you have to do HBsAg, HBC and anti-HBS. That's what the recommendation says, but we are not doing
To see for protective
but ideal is
titers,
to do all those things.
I have just a comment about anti-TNF in ILD. I think that, I don't know, you do counseling for anti-TNF. We do, like, ILD is one of the contraindication before starting anti-TNF. So I think the safer options are abatacept, rituximab, even a tocilizumab might be safer. I don't know where you got the data. I don't know, it's been changed recently with the use of anti-TNF in ILD, but I never used anti-TNF in ILD.
Thank you. Rituximab would be a better choice, isn't it, Uma?
Rituximab
is a better choice. This is what I mentioned about the anti-TNF is from BSR-BR registry data. From where you work, I think, isn't it? So they said the anti-TNFs does not worsen the ILD. I mean, ideally, most of us in this room, I don't think we use anti-TNF as a first choice. Rituximab is better. Nowadays, tocilizumab, we have more data. And ideally, abatacept is also a good drug to be used.
Yeah, I agree. Abatacept and rituximab is safe for you.
Already we are exceeding the time by 2 minutes. So since we are short of time, we are actually moving away with tea break and making it a working tree. So somebody wants to have tea, you can just go have tea and come back. But do not move en masse. Do not.
All of you don't go out together, please. We are continuing with the talks. See, everybody is going out. No, it's not fair. It's not fair. So they want to
Okay, let's make it at least 5 minutes here. Please be back.